aneloplasty junction remodeling, ascending aortic graft, primarily for the dilatation of the sinus of valgus alpha, which is the aortic valve sparing reimplantation or remodeling with subcommissural aneloplasty, and also for the ventricular aortic junction dilatation, the subcommissural aneloplasty, and for perforation patch repair, autologous or bovine pericardium can be used for the repair. For prolapse repair type 2, plication, triangular resection, free margin resuspension patch can be used. A leaflet for the type 3 restriction, leaflet repair, shaving decalcification if the restriction was due to calcified leaflet or calcified commissures, and patch can be used. This is the definition of each subtypes. Dilatation of sinotubular junction, as you can see here. On the right side, dilatation of sinus of valgus alpha, the ventricular aortic junction, and perforation of the leaflet. This is when the cusp perforation, valve repair cusp perforation could be the sole reason of aortic insufficiency, either iatrogenic or healed endocarditis. Iatrogenic could be, for example, due to cathing, passing the wire across the aortic valve, or might injure the leaflet. A patch of fresh or glutaraldehyde fixed autologous pericardium is adequate to correct this problem. The patch should be larger than the defect because it retracts during healing. A continuous polypropylene to suture the patch around the defect on the aortic side of the cusp extension, used to repair incompetent aortic valves due to rheumatic and congenital disease. Glutaraldehyde fixed bovine or autologous pericardium has been used for this purpose. Cusp prolapse. Cusp prolapse is caused by elongation of the free margin. This is corrected by plication along the nodule of Arantes. The degree of shortening is determined by examining the other cusps and the level of coaptation of the cusps together. So as you can see here, this is a picture depicting the non-coronary cusp. There is a prolapse on the cusp, and the free margin is shortened by placating the area of nodal Arantes, as you can see here. This is another example of plication. Cusp with stress fenestration. Dilatation increases with mechanical stress along the free margin. It may cause stress fenestration with thinning, corrected by a double layer of 6-0 suture along the free margin of the cusps, as you can see here demonstrated. The double layer of the suture on the free margin of the leaflet. Bicuspid aortic valve, commonest performed aortic repair in adults. The anterior cusp often contains a raphe at the approximately where the commissure between the right and left cusps would be. Anterior cusp attached to the interventricular septum, and the posterior cusp attached to the fibrous component of alveoli. The cusp is usually the one that is elongated and prolapsed. As long as the posterior cusp is normal, repair is visible. The raphe is excised, and the free margin of the anterior cusp is shortened with plicating sutures. The length of the free margins of both cusps should be similar and should coapt at the same level. Suspending the arterial wall immediately above the commissures and observing the level of coaptation of each cusp gives an estimate of the level of coaptation of the cusps. Is very important point. Here, as you can see, the roughie of the bicuspid aortic valve repaired in the middle by doing a resection and then repairing the triangular cut or repair of the valve, the leaflet. Some surgical techniques. So as you can see here, is we have normal, prolapsed, and restricted leaflets and cusps. So essential to successful aortic valvuloplasty is the proper classification, of course, of aortic insufficiency mentioned previously. Aortic valve lesions may be categorized according to the range of motion of the cusp. So that's why we mentioned earlier that the cusp is very important to determine whether you can repair this valve or this valve should be replaced. By far, the best results for aortic valvuloplasty have occurred in patients with prolapsed leaflets. Prolapsing leaflet may be secondary to aortic dissection. In this situation, the commissures may be reapproximated and supraannular graft implanted above it. As you can see here, the commissures are sutured in a way that it's shortened to get rid of the prolapse effects. In more severe cases with extensive dissection in the aortic roots, it may be useful to sandwich the layers of the aortic with the Teflon felt, as it's here in the illustration. Here we have prolapse of individual leaflets may be seen with tricuspid or bicuspid valves. Particular interest in an interesting group of patients is represented by individuals with a prolapse of single cusps. How this is could be solved? This the technique was amended, leaving additional thickened tissue in the center portion of the cusp and using continuous double layer running suture to approximate the tissue. The redundant prolapsed tissue again is removed and excised, and then double layer running suture is done to correct the prolapse. Another thing is the aortic insufficiency is frequently associated with another dilatation. On the left is the normal here in this step down. The left is the normal coaptation of the cusps and the subvalvular triangle. Annular dilatation results in a widening of this subvalvular triangle with lack of coaptation in the central portion of the leaflets. So placement of horizontal mattress sutures buttressed with Teflon felt reduces the subvalvular triangle, increase coaptation, and reducing the annular circumferences. The technique for commissuroplasty is shown here. Horizontal mattress suture placed for the annulus at the base of the cusp, not including cusp tissue. The sutures results in a taller, narrower interleaflet triangle here, as you can see this in this side, and those greater leaflet coaptation. The narrower is the more close to each other, and the coaptation is achieved more with this technique. Um, the depth of placement of sutures directly affects the amount of reduction in the annulus. Suture placement high in the commissure significantly increase the leaflet coaptation and decrease the annular circumferences. Suture placed lower in the commissure results in greater leaflet coaptation and increased plication of the annulus. This illustration of the annular plication is incorporated in the surgical repair of all prolapsing leaflets, as the adequacy of coaptation can be appreciated from the intraoperative photograph, as can be seen here. Here is a bicuspid aortic valve with the Rafi shown in picture 15. And in this case is as mentioned previously, the Rafi is located mostly between the right and the left coronary cusp in 60% of patients, is present in the base of the conjunct leaflets. This Rafi may be the source of restricted leaflet motion. In this case, the cause of insufficiency in a bicuspid valve is a prolapse of the conjoined leaflet. The free edge of the conjoined leaflet is longer than the opposites and also thicker due to the Rafi. So triangular resection of prolapsed leaflets is carried at the midpoint. The completion of this show equal after the suturing both parts of the uh, equal length of the two cusps of the aortic valve achieved, as also here indicated in the picture 19 with triangular section of the conjoined leaflets. And here 20 showed excellent coaptation after examination of the leaflet, excellent coaptation of the leaflet. Here is statistics of most commonly done repair. Capital commissuroplasty has the the highest number of cases done by this capital commissuroplasty. As you can see, can be seen, followed by plication, less than 30%, root implantation, resuspension. Also, figure of eight is lower still, but I think more and more will be in the future. Operations used to the aortic valve sparing operation used to preserve the aortic valve in patients with aortic root aneurysm or ascending aortic aneurysm with aortic insufficiency. Dilatation of the ST junction displaces the commissures of the aortic valve outward and prevents coapting of the leaflets. Asymmetrical commissures of non-coronary cusps are often affected. If the other components of the aortic roots are normal, simple adjustment of the ascending restores valve competence. Problem with the ascending aorta is not with the valve itself here. This is accomplished by transecting the ascending aorta 5 millimeter above the ST junction and pulling the commissures upward and close to each other until the cusp coapts. Three commissures from an imaginary triangle drawn down here. The diameter of the circle that contains this imaginary triangle is the diameter of the graft, because this triangle is not always equilateral, and the commissures must be spaced according to the length of the free margin of each cusp. So sizing the diameter of the circle with a transparent valve sizer is important. The Dacron graft is sutured right at the level of the ST junction here with a continuous 4-0 polypropylene suture. If after adjustment the cusps do not co-opt at the same level, one or more cusps elongation or shortening might be needed. Valve competence can be tested by cardiology until the graft and observing the LV cord distension. If the non-coronary aortic sinus is dilated, neo-aortic sinus can be created by tailoring the graft with a tongue of tissue that is sutured directly to the aortic annulus. The height of the new aortic sinus of Dacron should be 3 to or 4 millimeter more than the diameter of the graft, and the width should be also 3 to 4 or 4 millimeter more than the estimated intercommissural distance to allow the graft to bulge and create a new aortic sinus. Here is the new aortic sinus, excised the sinus and created with the dacron for the non-coronary aortic sinus. The large proportion, more than 30% of patients with root aneurysm has normal or minimally stretched aortic cusps, and an aortic valve sparing operation is visible. There are two types of aortic valve sparing operations for patients with aortic root aneurysm: remodeling versus reimplantation of the aortic valve. The ascending aorta is transected, the remodeling the ascending aorta is transected, and the aortic root is dissected circumferentially down to the level of the aortic annulus. All three aortic sinuses are excised, leaving approximately 4 to 6 millimeter of arterial wall attached to the aortic annulus and around the coronary artery orifices. The three commissures are gently pulled vertically and approximated until the cusps collapse. Three commissures form a triangle and the diameter of the forming the triangle and the diameter of the circle that contains that triangle is the diameter of the graft to be used for remodeling. The stentless valve sizers are very useful to determine the diameter of the graft. The spaces in between the commissures are marked in one of the ends of the graft, and the graft is tailored to create three new aortic sinuses. This can be seen here: dilatation and remodeling of the aortic root. The aortic sinuses are excised, leaving 4 to 6 millimeter of aortic wall attached to the aortic annulus and around the coronary buttons. Here is the graft of a diameter equal to the diameter of the sinutibular junction is tailored to recreate three aortic sinuses. The three commissures are suspended into the uh, tailored graft, and the new aortic sinuses are sutured to the aortic annulus and remains remnants of arterial wall. The height of these new aortic sinuses should be approximately equal to the diameter of the graft. Three commissures are suspended in the graft, which is then sutured to the remnants of the aortic wall, close to aortic annulus with continuous 4-0 polypropylene sutures. The coronary arteries are re-implanted into the respective new aortic sinuses. This is the complete picture. So the aortic cusps are inspected to make sure that all three act at the same level. Very important. Aortic valve competence can be assessed by injecting cardioplegia. The graft is then anastomosed to the distal aorta. The modeling may be inappropriate for patients with aortic root aneurysms associated with genetic syndrome and annular aortic ectasia. Reimplantation, the second type, This procedure can be performed in all patients with aortic root aneurysm, but it is particularly valuable in patients with dilated aortic annulus. It's technically more demanding than remodeling. In the original description of this procedure, the aortic valve was reimplanted into a tubular Dacron graft, and no new aortic sinuses um, were created. This is now a commercially available graft. There is now commercially available grafts with sinus of Valsalva. The three aortic sinuses are excised. The horizontal mattress of 2 or 3 0 polyester are placed from the inside to the outside of the LVOT below the aortic annulus, horizontal plane from the nadir of the left and the non-coronary cusps and slightly scalloped between the subcommissural triangle of the left and right cusps and this so long the membranous septum. These sutures frequently pass through the right atrial wall in the area of the membranous septum and left atrial wall in the area of subcommissural triangle between the left and non-coronary cusp. The tubular Dacron graft of diameter equal to double the average height of the cusps, minus 2 to 3 millimeter is selected, and three equidistant marks placed in one of its ends, as can be seen here. Reimplantation of the aortic valve sutures are passed below the aortic annulus in a single horizontal plane along the fibrous of the left portion of the left ventricular outflow tract and following the scallop shape of the aortic annulus along the muscular interventricular septum. Sutures are also passed from the inside to the outside of tubular graft, Dacron graft. The sutures were previously placed in the alveoli are now passed through the graft. If there is obvious dilatation of the aortic annulus, the sutures should be placed symmetrically along the muscular interventricular septum, but closer to each other beneath the subcommissural triangles of the non-coronary aortic cusp, because that is where dilatation occurs in patients with connective disorder. The sutures are then tied on the outside of the graft. The graft is then cut in a length of approximately 5 centimeters and pulled gently, and the three commissures are also pulled vertically and temporarily secured to the graft with transfixing for proline sutures buttressed on small different filled digits. But these sutures are not tied. Once all three commissures are suspended inside the graft, the commissures and the cusps are inspected, examined to make sure that they are all correctly aligned and coapted well. Next, the sutures are tied on the outside of the graft. Another running suture right at the level of the annulus and the remnant arterial wall start at the level of commissure and stop at the nadir aortic annulus where the sutures are tied together. The coronary artery is then reimplanted into the respective sinus. The coaptation of the aortic cusp is inspected and prolapse is corrected if necessary after the reimplantation. This is the final look uh, of the reimplantation. As you can see, the suture inside the graft and the coronary artery reimplanted again into their respective sinuses. It's important that the cavitation level is well above the aortic annulus. Creation of new aortic sinuses are by placating the graft at the level of the sinutubular junction. and in between two commissures allows the aortic cusp to move a bit more centrally as increased its mobility. Valve competence assist by injecting cardioplegia. The distal anastomosis is performed, then the graft sizes range between 26 to 34. The mean is 31, and this is how it's done. There are there are different types of valve sparing aortic valve or valve sparing replacement. Uh, aortic root replacement, David 1, reimplantation. David 1 is the original reimplantation procedure, which uses 23 to 30 cylindrical tube. The first one was, and then we have two remodeling, David 2 and 3. David 2 replaces the sinuses with three tungent dacron graft. The graft edge are sewn to the annulus with a small sinus remnant, as can be seen in the illustration. David 3 incorporates a strip of the bullet BTFE that is filled externally across the base of the non-coronary sinus from the trigone to trigone of the mitral valve in order to minimize subsequent annular dilatation. David 4 reimplantation technique using the 4 millimeter larger graft size with the graft plication at the sinotubular junction above the tops of the commissures. David 5 is the reimplantation, uses an even larger graft size than that predicted by the Fendel-David formula, which is nicked down at both the bottom and the top ends of to create graft pseudosinuses. As you can see, the portion proximal and distal portion of the graft are different in size. There is the David 5 reimplantation with the Stanford modification. This is a simplified David 5 procedure using two separate grafts. So larger grafts are used proximally for the pseudosinuses. This is nicked down on the back table. Plication suture in all three commissures to fix the annulus at the present diameter before tying the bottom row of the sutures. The bottom sutures line consists of 10 to 12 horizontal mattress sutures, which are tied loosely because the diameter of the proximal end of the graft has already been made smaller. In a study for the bicuspid aortic valve, it was found that the risk of reintervention during the first 10 years following bicuspid aortic valve repair is reported to be 5 to 22%. Published results of bicuspid aortic valve repairs tend to be slightly worse as compared with tricuspid valve repair. Here is a 2023 study comparing normal and collapsed valve, multi-center cohort study comparing normal over 1,000 comparing normal and prolapsed to calcified, fenestrated, and retracted valves. 2 years follow-up results in patients with calcification. They have increased risk of severe aortic regurgitation after repair, and fenestrated the patients with aortic valve fenestration. They have no increased risk of aortic regurgitation and reintervention. However, the patients with valve retraction they had increased risk of severe aortic regurgitation and reintervention. So, what was the results and the implications? Aortic valvuloplasty should be performed with caution in patients with retraction and calcification. Surgeons can successfully decide on aortic valvuloplasty feasibility in CASP administration patients. It was clear in administration group. Treatment remains important to the final choice of treatment in patients with CASP abnormalities. Those are what I found in the guidelines, European and American guidelines about the repair. Those guidelines does not mention if, for example, this point about surgery replacement or repair, they would mention surgery only. So as you can see, the last point here, the only one I found about aortic valve repair. In the left side is true. The left side is the 2017 European guideline, and then the right side is the 2021 updated one. So in the first 2017 heart team discussion is recommended in selected patients in whom aortic valve repair may be feasible alternative to valve replacement. This is class 1 was in 2017. Now it's a class 2B in 2021. Aortic valve repair may be considered in selected only patients at experienced center when durable results are expected. This is again for aortic valve, the valve sparing aortic root replacement. Our valve sparing root replacement is recommended in young patients with aortic root dilatation if performed in experienced center and durable results are expected. This is plus one recommendation in both in 2017 2021 in the American guidelines regarding the patients undergoing root replacement surgery, valve sparing aortic root replacement is reasonable if the valve is suitable for repair and when performed by experienced surgeons in a multi-disciplinary aortic team. Thank you very much for listening. This is my presentation.
Okay, thank you, Dr. Muslim, for this informative presentation. I have only one question here. Can you go back to this to the table that for the types of the valve sparing operations? You can hear me, Muslim?
Yes, sure. Just 1
Yeah.
second. Let me go. What do you mean?
Apart from the Yaqub procedure, all the David procedure here, the only difference is the conduit size, right? Apart from the last one, the one who contains two grafts. All the others, the only difference is the conduit size, right?
Yeah, well, yes, the David 5, the Stanford modification, they use two separate grafts, one
One,
smaller this and one larger proximal.
okay, the other types only they increases only the size, right?
They increase the size in the proxy in the distance.
Okay, they found any differences why they are modified because it has a better result or better survival or what is
I
their
think it's more physiological. If you take a look at the sinuses, they have different size from
no,
the
I
aorta.
I don't mean the type 5, the last one. I mean the different one. So they are just trying to mimic the physiology, then they created the two graft, right?
Yes, just to mimic the sinus, because the sinus is larger than the aorta, the ascending aorta.
And the result of this one, the last technique, did you find that the results are good here or what? Or you did not read it?
I didn't go through the results of David like the modified, but يعني I suppose adding a new procedure means there was a defect and we need to work on it. That's why we bring another thing to repair. But I haven't go into details about the
Okay,
results of modification.
okay, thank you, Muslim. I think Dr. Farid is with us. Dr. Farid, do you have any comment here?
Yes, thank you. And thank you for a very nice, comprehensive presentation. Just out of experience, very few people will ever now do the Yacoub procedure. You mentioned something about the drawbacks of that. Can you remind me what did you mention in your presentation?
Yes, Doctor, you mean the drawbacks of Yacoub
Yes.
Yacoub I'm not sure, to be honest, but I think maybe the suturing the tube when there is a remnant of the aortic of the original aorta, and the suturing it not in a horizontal matter, maybe it causes leak or restrict size of the an aortic root. It restricts the size of the aortic root. This
Yeah,
is what
just
I
like
can.
just like you see the tips of those scallops that we make when the graft are not supported, and therefore they are liable to dilate. And so that procedure does not prevent dilatation in the annulus and the regurgitation, development of aortic regurgitation down the line. So that was one of the major things. That's why the David's technique now is the most popular one. And it's once you do it a few times, 2-3 times, you really become very professional at that, and you should try to upgrade your skills to that level. One more thing I wanted to ask is, yes, so after this presentation, you mentioned few things that can make your repair not durable for a long time. What would make you, at the time of surgery or before the time of surgery, what are the things that will encourage you to consider repair of the valve? And what are the things that you should avoid, or if you see it, you would choose a different kind of repair, for example? So in summary, just tell us in few words, what did we benefit from this presentation regarding our surgical judgment? You see the patient in the clinic, and you meet about them with the multidisciplinary team. What will encourage you to do the repair?
Yes, I think the thickness of the cusps. One of the things very important. We need healthy cusps
So
to
you mean
repair.
if it's a normal looking cusp, you will be more encouraged to repair, right?
Yes, yes. Another thing that connective tissue disease patients, I would rather
Connective tissue disease on medications, on steroids, for example, or some other immune suppressions that affect the collagen formation. That also may be another consideration. Yes. Okay. What else?
another thing that I'm thinking of is a young patient. Maybe I would give
So
them.
with young patients, we'd encourage more for repair if it's feasible, right?
Yes, also because I would like to escape the vicious cycle of anticoagulation plus degeneration of fibrostasis, and these I could offer the patient maybe durable repair if he is young. That's one of the points.
Okay. What else? What would sway you
Uh,
away from repair? All these points that you have mentioned, anything against that, you probably will sway away from it, going for repair. So what else will يعني encourage you not to do repair?
I'm not sure about bicuspid aortic valve. There are results good and not, but I'm not sure really about it.
So if you are expert and you have done quite a few of these, you may start stepping into repairing bicuspid valve. There are reports of very good results for a long time with this kind of valve. So yes, in the beginning of your career, maybe you can refer it or help somebody or ask somebody to help you with the bicuspid in the beginning of your career. But once you have that experience with good results with the other techniques, then you should really try. As you reported, the results are variable because of the experience, from 5% to 20% or something like this, regurgitation, severe regurgitation recurrence. Okay, what else?
Dr. Farid, what about the unicasp and the quadricasp aortic valve? I haven't read about
Yeah,
maybe those.
in the congenital group, younger patients, of course, they have very limited choices for replacement, and the only chance to replace is the only way to replace is the Ross procedure, which is not bad. It has good track record for a long time. But still, with that, I would say attempting repair as a first procedure is indicated. Again, you would look at the leaflets, look at the length of the scalps, the leaflet itself, how much far is the sinuses away from the annulus, and how much coaptation edge would you develop at the end. If in doubt, and you have good annulus, I have attempted in the young generations to do cusp extensions, creating new cusps, basically 3 new cusps, and with good results and this is a temporizing procedure that will help patients. Many of the patients that have had this repair, it lasted them for 7 to 10 years. By that time, they have very good annulus for valve replacement. Another choice, of course, is the Ross procedure, and that can be a good alternative. The problem with the Ross is the limited experience among the surgeons. If you look at the STS data, it only has like 0.6% of all aortic valve replacements are made in the Ross procedure. So that's something to consider. Cuspis extension have gained quite a bit of popularity recently. We have reoperated on some patients who have cusp extension years ago, and amazing the way the leaflet look after so many years. Some of them are 15 or even 20 years later. So it can be a very good save for those patients. I didn't finish my question there before because I wanted you to mention about the retracted leaflets and the calcifications, and those are also very
From the study I mentioned, yes, those patients I would rather exclude them from repair.
Good. Yes. So those are the concerns, and the other thing, of course, in our country here, where you have a lot of rheumatic heart disease, and if you have any rheumatic activity, young age, and you attempt repair, the failure rate, if they're less than the age of 20, with active rheumatic fever, the rate of failure of the repair is almost 100% within 2-3 months. So those patients, you should concentrate in the beginning if the patient can tolerate medical treatment for some times, until you control the rheumatic activity before you think about repair. Successful repair can last for a long time, but if there is any doubt, like you still have some significant regurg, more than moderate or more, +2 basically, it's better to consider reconsideration at the time of surgery of either replacement or reconsider your repair or type of repair. What type of tissue would you use for repair? You mentioned bovine pericardial patches. Is there a room for using native pericardium?
Yes, yes. Using the native pericardium with the glutaraldehyde or without, this is one option, can be used as it's used in the procedure, Ozaki procedure. They are using the pericardium, native pericardium of the same patient to create the valve. I think also for fenestration or the penetrated valve, we can use pericardial patch. Yes, native pericardium.
Scholarly resident who will be trying to score very high in their boards. What's the function, or why do you use glutaraldehyde? What's the concentration of glutaraldehyde? Is it too much or is it too little? How does that affect? Of course, I mean, the answer to that is to control calcifications and to kill all the live cells and maintain the structure at the same time. But there is a limitation. There are experimentation with different concentrations that have resulted in a different rate of calcifications and a different rate of immunological kind of reaction to the tissue. Anyway, well, thank you very much. I think that's all for me.
Thank you, Dr. Farid. Thanks.
Thank you, Dr. Khalid. Anyone has any question or comment? Okay, so we will start with the survey for the first presentation. Please fill the survey so that we can start the second lecture. Dr. Noura, you are here with us?
Yes, I'm here.
Yeah, you can share your slides and we can start after 5 minutes.
Yeah,
Okay?
sure. Okay.
Dr. Noura?
Yes.
Yeah, you can start now.
Can you see my screen?
Yes, we see your slides.
Good afternoon. My name is Noura Razouk, and I'll be presenting on the mitral valve anatomy and pathophysiology of mitral valve disease. With the left atrium exposed, we can appreciate three main structures successfully. These are the atriovalvular junction, the leaflets, and the valve suspension system. The atriovalvular junction defines the hinge where the motion of the leaflets is initiated. This hinge allows the demarcation of the annulus, and the part where the annulus fibrosis, the part of the annulus fibrosis where the leaflet attached is located deeper and 2 millimeter external to this hinge. This anatomical relationship has an important surgical implications in valve reconstruction, since the suture used to secure the prosthetic annulus or the prosthetic ring should be passed through the annulus and not through this hinge in order to preserve leaflet motion. Thus, sutures must be placed 2 millimeter away from the hinge and oriented towards the ventricle in order to pass through the resistant fibrous body of the annulus. The annulus fibrosis is actually a discontinuous band of connective tissue that exists only in some part of the attachment of the posterior leaflets, and it does not exist at the attachment of the anterior leaflet because of the continuity of the aortomitral curtain that is shown here in this diagram, that extends from the aortic valve annulus, particularly between the left coronary and the non-coronary cusps, to the base of the anterior leaflet. The annulus of the mitral valve extends parietally from the two fibrous trigones, which are components of the fibrous skeleton of the heart, and are defined as the greatly thickened areas as shown here in the at either end of the fibrous continuity between the leaflets of the aortic and the mitral valve. The shape of the annulus during systole and diastole varies. For example, during diastole, the shape of is grossly circular. However, during systole, it has a kidney shape. The area of the valvular orifice related to the fibrous trigone and central fibrous trigone is most vulnerable with the respect of the AV node and the penetrating bundle. This dissection here is made by removing the non-coronary cusp of the aortic valve, and it shows the approximate location of the AV conduction axis as shown here in the hatched area, and its relationship with the mitral valve to the ventricular system. As mentioned earlier, the mid portion of the aortic leaflet and the mitral valve is attached. The non-coronary cusps of the and the left coronary cusps of the aortic valve and the anterior leaflet or the aortic leaflet of the mitral valve is attached through the by the aortomitral curtain. An incision through this curtain can be made to extend the subaortic outflow tract in cases of enlarging the aortic annulus during replacement. This diagram or this image shows the proximity of the circumflex coronary artery and the coronary sinus and the atrioventricular node. The circumflex artery is adjacent to the left half of the posterior or the mural leaflet of the mitral valve, whereas the coronary sinus is adjacent to the right half of the mural or the posterior leaflet of the mitral valve. And these structures can be damaged during excessive dissection or by excessively placing a deep sutures during replacement or repair. The mitral valve leaflets are divided into two zones. The first zone is the smooth or the body zone, and the second zone is the coaptation zone or the rough zone. On the atrial surface, the leaflet exit on the atrial surface. This zone can be appreciated. The coaptation zone or the rough zone is irregular in appearance and appears thicker due to the numerous cordae attached to its ventricular side. And you can appreciate here the gently curved coaptation line between the two leaflets that is evident from the atrial view that separates these two regions or these two zones. The coaptation zones of the valve is critical for valve competency, and the depth and the length of the coaptation zone is now often viewed as an important assessment tool of the mitral valve function. You can see here both mitral leaflets from the upon dissecting the left atrium. And you can appreciate the markedly different appearance of both leaflets. For example, the aortic or the anterior leaflet is relatively short and square in shape and guards approximately 1/3 of the circumference of the valvular orifice. This leaflet, as I've mentioned earlier, is the one that is in fibrous continuity with the aortic valve. And because of this, it is termed aortic leaflet, because it's neither strictly anterior nor superior in position. The other leaflet is much shallower, but guards approximately 2/3 of the circumference of the mitral orifice. And because it's connected to the parietal part of the atrioventricular junction, it is most accurately termed mural leaflet, but most often termed posterior leaflet. And this leaflet is divided into a number of subunits called scallops. There are generally 3, but there can be as many as 5 or 6. One characteristic of the anterior leaflet is that during diastole, the anterior leaflet divides the left ventricle into 2 functional areas. That is the inflow chamber and the outflow tract. In this image, we can appreciate the appearance of the scallops and the indentation between these scallops and the corresponding areas of the anterior in the anterior leaflet. You can appreciate here the freely deep, the free edges of that is deeply scalloped into 2 indentation, and these indentations appeared due to the attachment of the cordae inferiorly. The posterior leaflet has 3 scallops generally. Termed P1, 2, and 3, to facilitate valve analysis and to allow the leaflet to fully open during diastole. And by convention, the corresponding areas of the anterior leaflets are called A1, 2, and 3. You can also appreciate the appearance of the 2 commissures, the anterior and the posterior commissure. Now, the size of the scallops of the posterior leaflets differs, the largest being the middle scallop of the P2, and the smallest is the P1. Due to the size of the large surface area of the P2, it is exposed to a higher stress. That's why it has a higher frequency of the prolapse compared to the P1 and the P3, which have much smaller surface area. And this image further clarifies the distribution of the scallops and of the posterior or the mural leaflet and its corresponding areas of the anterior or the aortic leaflet. Now, after we have gone through the leaflet, the commissures, we have gone through the scallops of the left of the posterior leaflet. We can appreciate the presence of the commissures. There are two commissures of in the mitral valve, termed anterior and posterior commissure. The commissural leaflet is small, triangular in segment, and its base is attached to the annulus, and its free edge is supported by one or two chordae that has a fan-like characteristic fan-like in shape. As a result of this configuration, the junction between the anterior and the posterior leaflet does not reach the annulus, but rather forms a Y-shaped line of coaptation. The subvalvular apparatus contains two important structures. These are the cordis tendineae and the papillary muscle. And their function is to facilitate the opening during diastole, opening of the leaflet during diastole, and to prevent upward displacement or prolapse of the leaflets above the plane of the annulus during systole. The papillary muscles inserts into the ventricular wall and are usually organized into two groups, as seen here: the posteromedial and the anterolateral papillary muscles. Generally, they have 5 configurations. The anterior papillary muscle most often has type 1 configuration, with occasionally an adjacent type 3 configuration papillary muscle attaching to the commissural chordae. And the posterior papillary muscle, or the posteromedial papillary muscle, has usually type 2 configuration. The anterolateral papillary muscle is vascularized by multiple branches from the anterior descending coronary artery and either the diagonal or the marginal branch of the circumflex vessel. The posteromedial group is vascularized by a rather smaller supply from the circumflex artery or the RCA. These differences between the vascularization of the papillary muscles explains why the posteromedial papillary muscle is more prone to necrosis and dysfunctions than the anterolateral papillary muscle. The chordae tendineae extend from the it has 3 types described upon their attachment on the leaflet: the basal or the tertiary chordae, which extends from the papillary muscle or directly from the ventricular wall; the intermediary or the secondary chordae, which are attached to the ventricular side of the leaflets; and finally, the marginal or the primary chordae, which are attached to the margin of the leaflet. And the chordae tendineae can also be classified or described in relation to their insertion in different segments of the valve, from the midline of the anterior leaflet towards the commissure, you can appreciate the presence of one or two thin paramedial chordae attached to the margin. And you can also see here the main chordae that is attached to the ventricular surface, which has a thick and resistant appearance. Another description is another configuration of the chordae is the paracommissural and the commissural chordaes, with the commissural having the characteristic fan-like appearance and the insertion in the commissural leaflet. This is another image further clarifying the distribution of the chordaes to the papillary muscles and to different regions of the valve, the leaflet, sorry. As I've mentioned earlier, there are certain structures that can be that can be injured through when during valve reconstruction. These are one of them is the circumflex artery, which runs between the base of the left atrial appendage and the anterior commissure, with a distance of 3 to 4 millimeters from the leaflet attachment. Another structure that can be injured is the coronary sinus that skirts around the valve or the attachment of the posterior leaflet. The bundle of his is at great jeopardy due to its close proximity to the posteromedial trigone. Also the non-coronary and the left coronary cusps due to its again close relationship to the base of the anterior leaflet. Particularly the nadir of these cusps can be most commonly injured during mitral valve replacement.
May I interrupt here for a second, please?
Yes, sure.
This is a very important slide from clinical part of it, meaning in your practice, you have to pay attention to these, but also it could be part of your board exams. Thank you.
Okay, so that's it for the anatomy of the mitral valve. Let's move on to the pathophysiology of different mitral valve diseases. We'll start off with the mitral stenosis. Mitral stenosis is generally the result of rheumatic heart disease, and non-rheumatic causes of mitral stenosis or the left ventricular inflow obstruction can include severe mitral annular calcifications in the elderly, congenital mitral valve deformities like mitral valve clefts, malignant carcinoid syndromes, neoplasms, left atrial thrombus, endocarditic vegetations, or in those cases who have had previous commissurotomy or implanted prosthesis. The pathoanatomical characteristics of mitral stenosis include commissural fusion, leaflet fibrosis with a stiffening and retraction, and chordal fusion and shortening. Now, leaflet stiffening and fibrosis can be exacerbated over time by the increased flow turbulence, and the degree of calcification varies and is more common or of greater significance and severity in men and older patients, and those with again high transvalvular gradient. Mitral annular calcification may progress to mitral sclerosis and stenosis in the elderly, especially those who have recurrent dialysis or dialysis dependent. The anterior leaflet can become thick and immobile, and the left ventricular inflow obstruction can result from this calcification, particularly calcification of the posterior mitral valve leaflet. Furthermore, calcific protrusions into the ventricle and the extension of the calcium into the leaflets can greatly narrow the valve orifice, resulting in severe mitral stenosis. And in such cases, the left ventricle is typically small and hypertrophied and usually non-compliant. The commissural fusion and leaflet thickening are the dominant features in a clinically important mitral stenosis. The commissural fusion, the characteristics of the fusion of the edges of the mitral leaflet in a commissural area is rather a complex process involving the coapting edges of the commissural, the mural, and the anterior leaflets. Valve leaflets are thickened to a varying degree. Again, this particularly at their three edges at the site of fusion. And calcification of these calcification usually begins at the commissure, but with time extending posteriorly into the annulus. The chordae can be variably involved by the rheumatic process. However, occasionally, sometimes or occasionally, the chordae can, in mitral stenosis, can appear normal in appearance. But most often, the chordae tend to be shortened, thickened, and yes, shortened and thickened. This image, in this image, we can appreciate the calcification of the mitral valve with a thickened, rigid nodular appearance of the mitral valve viewed from the atria in the left upper image. And we can also appreciate the calcium that is present in the commissures, and we can appreciate that the fusion, the commissural fusion here, in both the right upper image and the left lower image. The whole, you can also appreciate that the whole subvalvular apparatus is thickened and fused altogether. All of these pathological changes can be compared with this left right lower image, showing a healthy subvalvular apparatus and healthy annulus. This is an echocardiographic representation of the pathological changes in the mitral stenosis. In the left upper image, it shows the image shows a case of mitral stenosis and shows apparently the leaflet thickening. Severe mitral stenosis caused by rheumatic heart disease. We can also appreciate in the right upper image a thickened and stenotic valve separating an enlarged left atrium and left ventricle. And we can also appreciate the characteristic commissural fusion pointed here by the red arrows. Yes, and we can also see the doming of the anterior mitral leaflet. Now, we have gone through the pathoanatomical changes in the mitral stenosis. hemodynamics of the mitral valve can be severely altered due to the presence of these pathanatomical changes. And in patients with mitral stenosis, an early and middle and late diastolic transvalvular gradient is present between the left atrium and the ventricle. Now, as the degree of the mitral stenosis worsens, a progressively higher gradient occurs, especially in late diastole, with the average left atrial pressure reaching up to 25. Another physiologic measurement in patients with mitral stenosis is the cross-sectional valve area, which is calculated from the mean transvalvular pressure gradient and the cardiac output. The relationship between the transvalvular flow and gradient can be summarized in this equation. For example, doubling the flow quadruples the gradient. These are summary of the hemodynamical changes in patients with mitral stenosis. Now, the left ventricular diastolic volume can be normal in patients with mitral stenosis. However, the end diastolic pressure is low. The inflow obstruction of the LV can lead to also reduced peak filling, as is the stroke volume, and approximately 20 to 50% of the patients with mitral stenosis have left systolic dysfunction due to accompanying mitral regurgitation of aortic valve disease or ischemic heart disease, rheumatic myocarditis, pancreatitis, and myocardial fibrosis. In such cases, in such cases that have reduced peak filling and low end diastolic pressure, cardiac output is thus diminished as a result of this inflow obstruction, leading to the underfilling of the ventricle rather than pump failure. In patients with not so severely progressed mitral stenosis, the left ventricular ejection fraction may result in may be normal or slightly increased. However, with time, the LV filling is compromised by the shorter end diastolic period and higher heart rates, resulting in left ventricular systolic dysfunction. As for the atrial adaptation, because of the stenotic valve, the left atrial contraction is important in maintaining adequate transvalvular flow. And the high left atrial pressure gradually leads to left atrial hypertrophy and dilatation, and in some cases atrial fibrillation and atrial thrombus formation. The degree of left atrial enlargement and fibrosis does not, however, correlate with the severity of the valvular stenosis, partly because the marked variation in duration of the stenotic lesion and the atrial involvement by the underlying rheumatic inflammatory process. There are major determinants of the atrial fibrillation in patients of rheumatic heart disease, and these are old age and larger left atrial diameter. Now, the normal mitral orifice area is 4 to 6 square centimeters, and under normal physiologic conditions, the pressure of the left atrium and the left ventricle during diastoles are equal. As we know, the left ventricle gets filled with blood during early ventricular diastole, and with leaving only a small amount of blood that remains in the left atrium. And with the contraction of the left atrium, or the atrial kick, during late ventricular diastole, this small amount of blood fills up the left ventricle. Now, in cases of if mitral valve area is less than 2 square centimeters, this causes impediment of the blood flow to the left atrium into the left ventricle, and it creates pressure gradient across the mitral valve. And as this gradient across the mitral valve increases, the left ventricle requires the atrial kick to fill the blood. And in cases with a more severely stenotic valve or a smaller areas, there is an increase in the left atrial pressure. You can appreciate here the normal numbers, or the normal pressures. And the left ventricle is approximately 10, and with a mean gradient of 20. However, in severe mitral stenosis, the stenotic valve will cause the left atrial pressure to reach about 25. This pressure is then transmitted to the pulmonary vasculature, resulting in pulmonary hypertension. And as this pressure develops or remains elevated, the left atrium will increase in size, and as it increases in size, the greater the chance of developing, there's a greater chance of developing atrial fibrillation. And when that happens, the atrial kick is lost. Thus, in severe mitral stenosis, the left ventricular filling is dependent on this atrial kick. With the loss of the atrial kick, there is a decrease in cardiac output and sudden development of congestive heart failure. Pulmonary vascular resistance may increase in patients with severe mitral stenosis. This increase may be the results of spasm in the arterioles, presumably a reflex from the left atrial enlargement and hypertension, as mentioned earlier. And in patients with mild to moderate mitral stenosis, the pulmonary vasculature resistant can be sometimes can be absent sometimes. But however, the pulmonary arterial pressure can also be normal, but sometimes in severe conditions, rising the pulmonary arterial pressure rate can remain normal in the milder or moderate mitral stenosis, rising only with exertion of the heart. However, in severe chronic mitral stenosis, there is an elevated pulmonary vascular resistance and elevated pulmonary arterial pressure at rest, and this can approach the systemic pressure with exercise. And the pulmonary arterial systolic pressure greater than 60 millimeter of mercury can significantly increase the impedance of the right ventricular emptying, and produces a high right ventricular end-diastolic and right atrial pressure. With the rise of the atrial pressure, there are some cases that can develop tricuspid insufficiency, and rarely pulmonary insufficiency. This is for reference is the Wilkins score and the grading of the Wilkins scores. This is for your reference, but however, it is out of the scope of this. I will not go in detail through this classification, as it is outside the scope of the presentation. This is also a slide showing the echocardiographic classification of the severity of the mitral valve stenosis. Now that's it for the mitral stenosis. Now let's discuss the mitral regurgitation. Now there are different causes of mitral regurgitation. These termed the most common cause is the myxomatous degeneration, which is the primary mitral regurg, and the ischemic heart disease. The other causes is ischemic heart disease, which is a subset of the functional mitral regurgitation. Other causes include rheumatic valve disease, mitral annular calcification, infective endocarditis, and congenital anomalies, and echocardial fibrosis, myocarditis, and some collagen vascular disorders. Now, the structural changes of the in the mitral valve regurgitations can be one of the following, or can be a combined structural changes. These are the leaflet retraction from fibrosis and calcification, annular dilatation, or chordal anomalies, including rupture, elongation, or shortening. These structural changes can be accompanied by left ventricular systolic dysfunction with or without papillary muscle involvement. Now, the Carpentier classification have been designed according to three pathoanatomic types based on the mitral leaflet motion. The type 1 or the class 1 is defined as the normal leaflet motion. The type 2 is the leaflet is prolapsed, or it shows an excessive motion. The type 3 shows the leaflet is characterized by type 3 when it shows a restricted motion, and type 3 is further subdivided into type 3b, where the restriction is during systole and diastole, and 3a, where the restriction is during systole and diastole, and 3b, where the restricted is occurring only during systole. Mitral regurgitation with normal leaflet motion can result from annular dilatation, often secondary to left ventricular dilatation. For example, patients with dilated cardiomyopathy or ischemic cardiomyopathy can have type 1, can be classified as type 1. As for the type 2, different examples include mitral valve or leaflet prolapse or flyal leaflet. The type 3 or class 3A can be caused by a rheumatic valve disease, or in type 3B can be caused by rheumatic ischemic mitral regurgitation or a functional mitral regurgitation, or in some cases dilated cardiomyopathy. Mitral valve prolapse is characterized by billowing of the one of or both leaflets into the left atrium during ventricular systole with or without mitral regurgitation. And the basic pathologic conditions behind it are mitral leaflet redundancy and myxomatous leaflet thickening. Myxomatous degeneration of the mitral valve, also known as redundant valve or floppy valve or mitral valve prolapse, these are all used interchangeably, are considered primary mitral regurgitation, and it's the most common cause of mitral regurgitation, afflicting 2 to 3% of the general population. Mitral valve prolapse can be acquired or congenital, acquired being in conditions such as fibroelastic deficiencies in older patients, or congenital such as in patients with Barlow's disease. Other causes include Marfan syndrome, Ehlers-Danlos syndrome, osteogenesis imperfecta, and aneurysm osteoarthritis syndrome. The mitral valve prolapse appears to be a result of different or multiple genetic pathways, and it can be sporadic or familial with autosomal dominant or X-linked inheritance. This picture demonstrates the different pathological or pathoanatomical changes between the Barlow disease, which occur typically in younger population, and the fibroelastic disease, which are typically present in older population. You can appreciate the image on the right, showing the Barlow's, the mitral valve changes in Barlow's disease, showing an excess and spongy and weak fibroelastic connective tissue constituting the leaflets and the cords. There are different mechanisms accounting for severe mitral regurgitation and in those with mitral valve prolapse. These include annular dilatation and rupture or elongation of the first order of chordae in about half of the cases. Some cases can present with annular dilatation without chordal rupture, and other cases can present with chordal rupture without annular dilatation. Chordal rupture related to the defective can be related to a defective underlying collagen disorder or underlying papillary muscle fibrosis or dysfunction or bacterial endocarditis, or some other conditions that was previously mentioned. The idiopathic chordal rupture can be one of the causes of the mitral regurgitation, and it is more or less localized chordal rupture, and is usually a variant of this the mitral valve prolapse syndrome, in which a considerable portion of the leaflet tissue is uninvolved by this process, and in most cases the posterior medial portion of the posterior leaflet is involved. Such condition can occur in patients with Marfan syndrome. Moving on to the functional and ischemic mitral regurgitation. Functional mitral regurgitation is the result of incomplete mitral leaflet coaptation in the setting of the left ventricular systolic dysfunction and dilatation, with or without annular dilatation. For instance, in cases of dilated cardiomyopathy or ischemic cardiomyopathy, and thus now termed secondary mitral regurgitation. Functional mitral regurgitation, it occurs most commonly due to non-ischemic cardiomyopathy. And the second most common cause is advanced valvular disease. For example, in aortic stenosis, it occurs, functional mitral regurgitation occurs in 40% of the patients with heart failure caused by dilated cardiomyopathy. And ischemic mitral regurg, which is actually a subset of the functional mitral regurg, occurs approximately in 15% of the patients with anterior wall involvement and up to 40% with of the patients with inferior infarct. Generally, the severity of the mitral regurgitation is related to the size of the area of the left ventricular akinesia or dyskinesia. The pathophysiology of the ischemic mitral regurgitation can be attributed to changes to left ventricular functional geometry and alteration in the annular geometry and abnormal leaflet motion or malcoaptation, along with increased interpapillary distance and papillary muscle alignment, leading to apical thickening and tethering of the leaflet with the restricted leaflet motion. And because of the interdependence of the element constituting the valvular ventricular complex in ischemic MR, disruption of any component such as LV geometry or annular geometry can result in mitral regurgitation. Another cause of mitral regurgitation is rheumatic disease. And it is unknown why rheumatic fever can sometimes lead to mitral stenosis in some patients and pure mitral regurgitation in others. However, in cases of mitral regurgitation caused by rheumatic disease, there is diffuse fibrous thickening of the leaflet with minimal calcific deposits and relatively non-fused commissures. The other pathoanatomical changes can sometimes include chordiotendyny, although not extreme. In such cases, they're not extremely thickened or fused as in mitral stenosis caused by rheumatic disease. Fibrous infiltration of the papillary muscle can occur, and asymmetric annular dilatation can occur also primarily in the posterior medial portion. Now, during the first episodes of rheumatic fever, which occurs in adolescents or age 9 to 10 years, patients may develop acute mitral regurgitation, which is more frequently related to annular dilatation and prolapse of the anterior and posterior valve leaflet. The primary cause of this regurgitation in this circumstance, with the valve leaflet showing edema and only virtually normal chordae. Then after the remission of this acute process, regurgitation may regress spontaneously. And presumably this is due to because as the myocarditis heals, the heart becomes smaller and the annular dilatation regresses. In most cases, however, there is a progressive leaflet thickening, and particularly of the posterior leaflet, which becomes retracted and rolled in with shortening of the chordae. The anterior leaflet, however, is less thickened, and major chordaes are to a lesser extent involved, but if so, they are frequently elongated, allowing leaflet prolapse. Commissural leaflet can, in the chronic process, can be sometimes involved, and are, if involved, depending on the severity, they can the leaflets can be obliterated and fused, however, remain more or less open. Another condition that can cause mitral valve regurgitation is the mitral annulus calcification, and it's a degenerative disorder that is usually confined to elderly individuals. Most patients are older than 60 years of age, and women are affected more than men. And the pathogenesis of this disease is not known, but it appears to be, from theory, a stress-induced phenomenon from either associated with a systemic hypertension, hypertrophic cardiomyopathy, aortic stenosis, and occasionally advanced Barlow's disease. Other predisposing factor, as I've mentioned earlier, is include chronic renal failure, or those patients who are dialysis dependent, and diabetes. Also, aortic valve calcification can be an associated finding in 50% of the patient. And this is an echocardiographic image demonstrating the different extent of the calcification along the mitral annulus. And the left image, you can appreciate a very small localized calcified annulus, or in the right, compared to the right image, calcification can progress to a massive and rigid and concentric bars up to 2 centimeters in thickness, involving the annulus and later on the mitral leaflets. There are certain complications involving mitral annular calcification. These include left ventricular dysfunction and the interruption of the conduction system, particularly the AV or the penetrating bundle. Other complications include, that is, in cases if the calcification is are mobile or friable, patients can develop systemic embolizations. Infective endocarditis is a relatively uncommon cause of pure mitral regurgitation compared with its etiologic frequency in aortic regurgitation. However, However, when the aortic valve is infected and regurgitant, vegetations may drop down onto and infect the central portion of the anterior mitral leaflet, producing perforation and mitral regurgitation. And in the absence of the aortic valve disease, a normal or abnormal mitral valve may become infected with destruction of the cusps or the chordae or both. Submitral left ventricular aneurysms can frequently result in mitral regurgitation. Aneurysms can be multiloculated and have well-defined neck situated immediately beneath the posterior mitral leaflet. And mitral regurgitation in such cases can coexist because of the aneurysmal distortion of the leaflet, particularly the posterior leaflets of the mitral valve. This is an echocardiographic image showing the lung axis parasternal view with the presence of an aneurysm in the basal portion of the left ventricle. And you can appreciate the severe mitral regurgitation in the color Doppler image. It's in the upper right. And you can see the arrows pointing to the aneurysm that is fistulated in nature. There is another image, a cardiac CT or CTA, illustrating submitral aneurysm dilatation, showing the communication with the left atrium and the left ventricle. That sums up my presentation. These are my references, and thank you all for your attention.
Thank you, Dr. Noura. It was a very comprehensive presentation. Anyone has any question? Dr. Farid, you have any comment?
Well, thank you, Anwar. I think this is an excellent presentation for the basic science that you need for your clinical practice, as well as for passing the boards. One of the questions that usually comes is, how do you measure the gradient from the echo using the echo data? You went over that slide, but I think there was a typo mistake in that slide. So can you tell us what's the formula that we use for the mitral valve gradient measurement?
You mean Dr. Haim, how to calculate the gradient?
Yeah, so you're having the echo results. We'd like to know the gradient of that particular mitral valve or the aortic valve or whichever valve we're looking at. I think there was a typo in the slide that you have presented. You don't have to go there. If you know it, if you know the formula, you can mention it. Otherwise, we can ask somebody else. But it's a very significant formula that every senior should know in details. You get this to know this, I think, in your rotation with in the echo department. So there are two formulas that we usually use. One of them will be dependent on the pressure gradient that will give you an idea of the pressure difference, and that can give you an idea of the gradient. So you measure the velocity below the valve and above the valve, and you calculate from that what's the what's the gradient in that patient. Um, does anybody have a volunteer? Do we have a volunteer here for this? Okay, I will
The
send it in.
modified, is the doctor modified Bernoulli?
Exactly, yes, a simplified Bernoulli. Yeah, I think everybody should know that. The other one, of course, is the one we use, the pressure half-time formula. I I will send it in the chat for you. But very nice presentation and very good basic science that I think everybody should review this at least a couple of times before you embark into your clinical rotation. Thank you.
Okay, thank you, Dr. Farid. Can we have the quiz now? Okay, we will start with the survey first, then we will take the quiz for the second lecture. We will have the quiz now. I prepared 8 questions. Just 1 minute, and we will just upload it. It's okay. It's uploaded now. You have 8 minutes to answer the question, then we will discuss the question one by one. Okay, so now we can start with the first question. So the first one is, which of the following is true regarding the mitral valve anatomy? A. The right fibrous trigon is a part of the central fibrous body of the heart. B. The highest point of the mitral annulus is at the commissures. C. The mitral annulus increases in size during early systole. D. The posteromedial papillary muscle is larger and typically has one major head. Or E. Second order chordae prevents the leaflet prolapse. So who can answer this question?
كلهم تقولي
You can hear me, guys? You can hear me or no?
we can hear you. بس الكويشنز ما هي موجودة مرة.
Okay, can we just upload the questions again? It suddenly vanished. Okay, so who can answer the first question? Dr. Hammam, you are with us? دكتورة ذكرى؟ دكتورة سيرين؟
I can answer.
Okay.
So the correct answer would be the right fibrous trigon is part of the central fibrous body of the heart. Because together with the membranous septum, it constitute the central fibrous body.
Yes, the answer is A. Thank you, Dr. Nora. So the commissures will be the lowest point of the annulus, so it is wrong here. During the mobility of the mitral valve annulus, the mitral valve annulus will decreases rapidly in size during the early systole, so C is wrong. D, the anterolateral papillary muscle is larger and typically has only one major head. D, the primary chordae, it's responsible about preventing the leaflet prolapse. And about 50% of you guys answered the answer A, the right answer. So 2, which is accurate according to the Carpentier classification of the mitral valve. A, type 3B, which is excessive motion during systole. Type 1, which is isolated leaflet prolapse. Type 2, annular dilatation. Type 3A is excessive motion during diastole. And type 3B, which is the ischemic mitral insufficiency or ischemic MR. And the answer here is E. Because type 1 is the normal leaflet motion So it can be present with annular dilatation or leaflet perforation. Type B is the excessive leaflet motion. Type C is the restrictive, and is divided into type 3A and type 3B. Type 3A during systole and diastole, which is usually in rheumatic, and type 3B during systole, which is usually in ischemic or dilated cardiomyopathy. The third question is which is correct concerning the degenerative mitral insufficiency? A. There is excessive fibroelastic tissue in the elderly. B. The spongy connective tissue can affect the chordal tendon. C is that the annulus is not involved. D. Most patients with a prolapse will eventually develop symptoms. E. Chordal rupture in older patients is almost always associated with combined anterior and posterior. And the answer is B, which is the spongy connective tissue can affect the chordae tendineae. It's wrong because the etiology is usually fibroelastic deficiency in elderly. The annulus is usually or commonly involved, and it usually becomes thickened and dilated. And most patients regarding C is that regarding D, that most patients with a prolapse will not develop. Some patients will have only prolapse without symptoms. And regarding E is wrong because the chordal rupture in older patients is usually associated with B2 rupture or prolapse, and combined pathology is least common. The fourth question, which is a 72-year-old male, comes to the office with intermittent symptoms of dyspnea on exertion, palpitation, and cough, occasionally productive of blood. On cardiac auscultation, there was a low-pitch diastolic rumbling murmur and is faintly heard toward the apex, and the origin of the patient's problems it's usually related to what? A. Rheumatic fever as a youth. B. Long-standing hypertension. C. Silent MI with the past year. Or D. Congenital. So here, if you read the question, the diagnosis here or the physical examination and the history is more consistent with mitral stenosis, and MS is usually caused by rheumatic fever, so the answer is A. The fifth question is that in a 30-year-old asymptomatic female with a newly diagnosed mitral valve prolapse, which of the following is true? A. Echo will demonstrate displacement of one or both mitral leaflets posteriorly into the left atrium during systole. B. Migration of the systolic click and systolic murmur toward the first heart sound will occur during squatting. C. Prophylactic beta blocker therapy is indicated. D. Significant mitral regurg is likely to occur in more than 50% chance in her life. E. Restriction of exercise is advised to reduce the risk of sudden cardiac death. So here the correct answer is A. So the echo will demonstrate a prolapse or displacement of one or both the leaflet to the left atrium during systole. The sixth question is that which of the following is a complication of a floppy mitral disease? A. Shortening of the chordae tendineae, elongation of the chordae tendineae, rupture of the chordae tendineae, or nothing happened to the chordae tendineae. The right answer is that B. Elongation. Usually, the floppy mitral valve will come to as elongation of the chordae tendineae. The seventh question: what is the commonest cause of MS? And it's usually rheumatic. So the answer is A. The final question is that which of the following statement is pertaining the pathology of the pathophysiology of the mitral stenosis is correct. So A, an increased heart rate will shorten the diastolic filling time and increase the LA pressure. B, an increased heart rate does not affect the filling time and has no effect on the LA pressure. C, an increased heart rate will lengthen the diastolic filling but has no effect on the LA pressure. D, an increase in heart rate will lengthen diastolic filling time and increases the LA pressure. So we said that in the mitral stenosis, there will be like a limitation of the LV inflow. So if the patient developed tachycardia, there will be the heart rate will increase and the diastolic filling time will be reduced, and this will affect the LI pressure, so the LI pressure will increase. So the right answer here is A. Okay. Anyone has any question, or we can conclude our session for today? Okay. So we conclude our session for today. Thank you for the presenter, Muslim and Noura, and okay, thank you.